go over to Dr. Suvan for his talk on sudden intraoperative anterior chamber shallowing. Thank you.
Can we have someone switch those main lights off, the halogen lights?
Thank you, Sudeep, for this kind invitation. And I'll be moving on to sudden intraoperative shallowing of the anterior chamber as soon as we have the slides. Yep. I have no financial interest. Okay. So this is a surgery in progress. You can see the air bubble well in place. That means the anterior chamber was good to start with. And trypan blue was fine, and viscoelastic also. Enough room for the viscoelastic. And now hydrodissection starts, and this is when the problem begins slowly, and it's getting a little difficult over here, and little bit of burping, not very helpful. Further hydrodissection, and then that's when the action begins. Look at the iris prolapsing, and now it's full-fledged drama. So you know what's the problem. Iris is prolapsing, anterior chamber is shallow, the eye has become hard, the surgeon is in trouble. So try to repose it, doesn't work very well. And so what do we do next? So do an immediate digital intraocular press check and see if it's low, it's probably an inflow-outflow mismatch. And if it's a high pressure, then it's an urgent situation where we need to attend to it. We need to take care of the external forces, fluid misdirection, acute suprachoroidal effusion, hemorrhage. Now, if it's excess fluid outflow, and that means the IOP is low, there is a high flow rate. If there's insufficient flow, there is obstruction to the phaco sleeve and inadequate bottle height. If there is positive pressure, you have mechanical pressure from a tight speculum, drapes, or from a retrobulbar hemorrhage, fluid misdirection syndrome, or a suprachoroidal effusion, or a suprachoroidal hemorrhage. We know that the anterior chamber is really generally has a very low volume, and this keeps decreasing with age, which is not working in our favor. So how do we correct these? We take care of the wound leak. Obviously, a loosened speculum works wonders. First thing that you must do is loosen the speculum, and we identify retrobulbar hemorrhage also. If still the digital intraocular pressure is high, you would think of an overfilled capsular bag because of overzealous hydrodissection, a fluid misdirection, or a suprachoroidal effusion or hemorrhage. Now, this comes by various names, and it's called vitreous expansion, infusion misdirection syndrome, acute intraoperative rock hard eye syndrome, and well, the various names. The bottom line is that the shallow anterior chamber with intraoperative rigid eye without a suprachoroidal effusion or hemorrhage, and it needs immediate intervention. So how does this happen? There is this zonular capsular diaphragm which permits fluid to go into the posterior segment, and it works like a valve and doesn't allow it to come back. So there is a shift of the lens iris diaphragm, and this will cause iris prolapse, and the surgeon keeps infusing more fluid and the eye gets harder. So these are the risk factors: pseudoexfoliation, previous trauma, radial tear in the anterior capsule, zonulysis, and posterior capsular rent. Yes, again, when you have a posterior capsular rent, again there is fluid seeping into the vitreous and working the same way. So the surgical steps where this could happen is when you have a hydrodissection issue with a small pupil, where you're doing blind hydrodissection, you're going over the capsular axis, rather anterior to the capsular axis, or when you have a PC rent, or during IA. Now, how do we manage this? Like we said, the causes will be external forces, fluid misdirection, and suprachoroidal hemorrhage. So the first step would be to remove irrigation, stop pumping in more fluid, and use a Q-tip or a sponge, swab stick, which we call, and you press it at the incision. This serves two purposes. It closes the incision, prevents further leak, and it creates an anterior pressure to counteract the posterior and somehow can break that valve mechanism. And you keep pressing for about 5 to 15 minutes till the pressure comes down, till the eye kind of softens. If it softens, it's okay to resume. We start with the low flow technique. If it's not okay, it's time to do an indirect ophthalmoscopy, and then you see a choroidal detachment, you manage it as a suprachoroidal effusion or a hemorrhage. And if there is no suprachoroidal effusion, you manage the fluid misdirection. So the management, I like Dr. Chakraborty said some time back, that putting in a needle into the vitreous is not always the wisest thing. Probably a full-fledged vitrectomy, a 23-gauge vitrectomy would be more prudent. Now let's see what happened to this in the surgeon's case. So they managed to push and reduce and somehow get that iris back, but this was no way they could do surgery further. They tried all the tricks, and then a little bit more of burping, and well, still not good enough. The pupil has become small, the eye is still hard, won't allow the phacoprobe inside, and that's when the surgeon chooses to go. Actually, a senior surgeon was called in, and they decided to do a 23-gauge vitrectomy, and once this was done, the eye softened, and it was possible to complete the surgery. Of course, I think here the surgeon probably chose to convert to ascites. Yes, so this was closed, the eye was soft, and now it was good for surgery. Now I'll show you something else. Now this is another surgery of my surgeries. Now, started off very well, no issues, no difficulty, a very clean case, and this is when something happened. As I pulled out my phacoprobe, the antechamber shallowed. I was inattentive. The wound was probably leaking, and then it became an exercise. The iris was prolapsing. I couldn't reposit it, and I tried Paul Arnold's technique, like I said, put a swab stick there and pressed as hard as I could. Right? Like I said, what we do is we are closing the wound leak, and we are putting pressure and trying to reverse that valve mechanism. And somehow I got a little bit of advantage over there. I could reposit that iris with a lot of effort, and then I could put in a suture over there. As I was going to put in that suture, a patient was under topical, a little apprehensive, and well, one squeeze, and all that effort nullified. Now it was tough job. I again pushed it, and I could not complete. I did a quick indirect. There was no suprachoroidal effusion, nothing. So, but the risk was, if I did, I had access to a vitrectomy. But if I did vitrectomy, I somehow a gut feeling told me that I could probably land up in an expulsive or a suprachoroidal. So I closed it up and did an ultrasound and came back within 7 days. There was nothing on the ultrasound. There was no choroidal effusion. It's absolutely fine. Clean ultrasound. So came back in 7 days. The cortex has become fluffy by now. And then you could actually do this in a couple of hours. You send the patient to the post-op room, wait for a couple of hours, and the eye softens, and then you can again go ahead and do the surgery. So this was about a week later. I actually spoke to the family once I had aborted the case, and they said they would like to come back after a week. So I allowed them to do that, no harm. So the take-home message would be, when you're taking out that phacoprobe, be careful to see whether the antechamber is shallowing or not. If it does, or if you have any doubt, please do inject viscoelastic simultaneously, so at least at the wound. You know, if you can go through the side port and inject near the wound as you're taking out the phacoprobe, so the antechamber remains maintained. Thank you very much for your kind attention. I invite you to Kolkata for this next conference, and forget the discounts. Come over there for the rasagullas.